There it is.
Absolutely. All right. Hello, everyone, and I want to welcome you to IR Center's Presenting Relief Without Surgery, a webinar about the genicular artery embolization procedure to help with knee pain. My name is Dr. Ari Isaacson, and I'm an interventional radiologist at IR Centers. What we're going to do tonight is I'm going to give you a short presentation about this procedure, and hopefully, while I'm showing you the slides and giving you information, that will spark some questions. So what I would encourage you to do is take those questions and put them in the chat. And at the end of the presentation, then I'll go through the chat and I'll answer all the questions. All right, so just be patient and we'll get to your questions. All right, let me start a little bit and talk a little bit about IR centers. So IR centers is a network of interventional radiology outpatient facilities. And if you're not familiar with interventional radiology, it's a subspecialty of diagnostic radiology, but what we do is minimally invasive procedures. And the reason it's associated with radiology is because we're using imaging to guide our procedures. And that imaging may be X-ray or ultrasound, or in some cases, CT scans. But that's why we are part of radiology. And we're able to do some really amazing things through very small puncture holes. So instead of having surgeries where you are cut open, you can come to an interventional radiologist and get a similar result just through a tiny puncture. So one thing I want to emphasize is that for genicular artery embolization, we at IR centers were the very first in the United States to do research on this topic. So over 10 years ago, we did the first research trial here in the US looking at genicular artery embolization and studying whether it would be a good treatment. And now here we are 12 years later, and we are using it regularly, so it turned out to be a good treatment. And we've passed down all of the stuff that we've learned to all of the interventional radiologists at every IR center so that we can have this standard of excellence throughout all IR centers. So a little bit about knee pain, specifically from something called osteoarthritis. So there's several different kinds of arthritides, but the one that we're talking about specifically tonight is osteoarthritis. And a lot of people know that as a kind of wear and tear type arthritis. And it is very common, especially as people age. And so you can see the numbers there. Millions of people have this type of arthritis. And sorry, hold on one second for me. All right, I apologize about that. And as far as people end up ultimately getting knee replacements, and that's how it usually gets treated eventually. But the question is, what do we do before someone's ready for a knee replacement? So we call that the treatment gap. I'm gonna go a little bit more into what that means. When you start having pain from osteoarthritis in the knee, usually initially people just do conservative things like rest it, put ice on it, use braces. Maybe they'll go to physical therapy. And then eventually you move on to a little bit more invasive stuff like getting injections. So getting a steroid injection or something called hyaluronic acid. A lot of people might know that as Synvisc. Those type of injections are extremely common. More recently, people have started to use things like PRP and stem cells in their knees, and that usually isn't covered by insurance. It's kind of a newer thing with less data to support it, but those are also injections that people get. And those tend to work okay for a while, but eventually they stop working that well. And now someone is kind of faced with the scenario, what do I do? Do I go on to get a knee replacement, or is there something else that can be done? And a lot of people aren't ready to have a surgery like a knee replacement. It's just maybe they feel like they're too young. They're worried about maybe the actual prosthesis, the knee that they're getting, that will wear out if they get it too early. So there's a lot of concern there. Fortunately, the procedure that we're talking about tonight, genicular artery embolization, or GAE, provides an answer, a solution to get people to buy them time until they need a knee replacement. So if the injections are no longer working and they're not ready for a knee replacement, a GAE can be a really good solution. So we're going to go a little bit into what we call the pathophysiology of osteoarthritis. how it works in the body and what actually causes it. Most people just think that it's wear and tear, that you use your knee enough and you kind of wear down your cartilage, and that's osteoarthritis. But there's actually a lot more to it than that. When the cartilage starts to wear away, it actually starts an inflammatory cycle inside of the knee. And the lining of the knee, called the synovium, becomes very inflamed. And there's this whole reaction of a bunch of different inflammatory messengers that get sent out. And ultimately, what that results in are new blood vessels growing in your synovium, in the lining. And they're not just they're not vessels you were born with. They're vessels that have now been created as a result of the chronic inflammation. Next to those blood vessels are new nerves. Again, nerves you weren't born with, but nerves that have now developed, and those nerves become very sensitive and account for a lot of the pain. And that's why this procedure works, because what we're doing is we're blocking off those tiny blood vessels that have newly formed. And in doing that, we're numbing those nerves that are adjacent to them and reducing the pain quite a bit. All right, so what do we know about what GAE does based on the research? We know that with this procedure, we can reduce people's pain by about half or even more. So if you come in and you say, well, my pain's an 8 out of 10 at times, with this procedure, we have the potential of dropping it to a 4 or even a 3 out of 10 just by doing a short hour procedure. And that effect can last, we've seen up to 2 years and maybe even longer. Also, we test functionality of the knee. So before patients come in, we'll do some questionnaires that test how well they can do certain activities. And we've seen also that the procedure allows a great improvement in functionality and what you can do with your knee afterwards. And then the next question is, well, is this a safe procedure? And it is. We've seen very few complications from the procedure, and when we do, they're mild, and they're things like getting changes in the skin coloration around the knee, or maybe a little bit of pain for the first few days after the procedure. All right, so let's look at the procedure itself a little bit more. It's a very precise procedure. We use X-ray imaging when we're doing it to make sure we get to the right spot. And basically, we are kind of taking down the fuel that is burning the inflammation inside the knee. So we're breaking the cycle of inflammation inside the knee. It is an outpatient procedure. So you come in, you have the procedure, which lasts maybe about an hour, and then you have about a 1 to 2 hour recovery, and then you go home. So very easy thing to do, to come in and just have a procedure in about 3 hours and head back. All right, so this is kind of a step-by-step process of how we actually do the procedure. We'll map the knee. So we'll insert a small catheter about the size of a piece of spaghetti, and we'll insert it into your artery, either in the groin area or maybe down by the foot, depending on who's doing the procedure. And then we use contrast dye with X-ray to show us a very precise map of all the arteries around the knee. We identify the arteries that are involved in the inflammation and also contributing to the pain that each patient has, and we target those arteries very specifically. Now, a lot of people say, isn't it bad to block arteries in the knee? Like, won't that cause problems to the knee, to the bones or the tissues in the knee? Well, again, this is a very specific targeting. We're only targeting these new vessels that have developed over time with inflammation. We're leaving all of the original blood vessels that were there open so that they can do their job, and we're just taking out the ones that are causing the inflammation. So after we do this procedure, it usually takes a week or two, or maybe up to a month, and then patients start to see the relief, the pain relief from the procedure. All right, so what does the procedure itself look like? Well, as we're doing it, we're using imaging. So initially we see a bunch of blood vessels that are inflammatory blood vessels, and then we block them with little tiny particles and at the end of the procedure, we no longer see those on X-ray because they've been blocked. So I'm going to show you a few images from an actual procedure so you can kind of see what we're looking at when we do this procedure. And so these are pictures from an 85-year-old male who had osteoarthritis of the right knee and was having pain, and he wasn't a candidate due to other problems with his health that didn't allow him to go under general anesthesia, and so this was a good option for him. All right, so here are just some pictures from the procedure. And And I want you just to see the before and after so you can see what we're looking at. So here's the catheter is right here. It's hard to see. It's a tiny little catheter, but it's right there, and it's injecting contrast dye. And so that's why what you're seeing here are blood vessels, and they're dark under X-ray because we've injected contrast dye into them. You can kind of see the outline of the bones as well. But we've used a technique called subtraction so that you can know the bones are no longer prominent and we can see the blood vessels much better. And what you end up seeing here, if you'll notice, there's a lot of smudginess. It's like this gray smudginess that you see everywhere. And those are actually those tiny blood vessels that we're targeting, not these big ones, but the little smudginess is what we're targeting. So afterwards, if you look at the bone now, that smudginess is no longer there. It's disappeared. And that's kind of what we're going after. This is a different blood vessel, but same idea. Here's the smudginess in this case, and afterwards, the smudginess is no longer there. You can see that. All right, so here's another more examples that we're going through. And you can see this is an artery of the knee that we would target, and here's the catheter in that blood vessel showing, again, a pretty pronounced smudginess that we're trying to get rid of. And just again here, you can see here's the blood vessel here, and again, smudginess there that we're going after. And just some more, same idea. More smudginess here. Again, it's gone after we embolize. This is pre and post. And then here's a pre-embolization here and another post with the smudginess gone. When we're doing the actual injections, we see kind of video. So this is an example of the video that we would see. Going as we inject the contrast dye under X-ray to look at the vessels of the knee. And again, another picture, same thing. Here's the catheter coming in, injecting contrast. This is actually the before on this side, and here's the after without the smudginess there again. All right, so the question is, are you a good candidate for GAE? Well, not everyone's a good candidate, but here are kind of what makes a person a good candidate. So we want people to have already tried other things before coming to this. This shouldn't be your first option when you have knee pain. So, at this point you should have maybe had medications or physical therapy or tried injections and it's no longer working out well. And then the other thing is, on X-rays, we know from research that if you have very severe osteoarthritis, if you have no more cartilage, then the procedure is less likely to work as well. It still works actually, but it doesn't work as well as if the arthritis is mild to moderate. And then on exam, if you can localize your knee pain, if you can say it's either on the outside of my knee or the inside of my knee, that's helpful. That usually tells us that we can be effective with the procedure. And then the last thing is, if you're ready to have a knee replacement, then you probably should go have a knee replacement. This is usually for people who are not ready to have that kind of surgery. All right, so what's procedure day going to be like if you were to come in and have this procedure? Well, you would come in, we would start an IV on you. We do give you a couple medications and get you ready to roll back into the procedure room. We would give you light sedation through your IV, so you're going to be awake for the procedure, but you should be relaxed. Some patients fall asleep, but they fall asleep on their own. We don't put you to sleep, but you will be relaxed. Now, the procedure is not painful, and that's something to stress. A lot of people are really worried about that, but it's really not a painful procedure at all. We'll give you a little numbing shot before we insert the catheter, and once the catheter is inside the arteries, you really don't feel that. So it's not a painful procedure, so that's not something to worry about. For the procedure itself, we'll go ahead and insert a catheter either in the thigh or the leg and run it through using X-ray and injections to take pictures like I just showed you. The procedure usually takes somewhere around an hour, and then afterwards we'll bring you to the recovery room so that you can recover from 1 to 2 hours. And the reason we do that is because we want to make sure you're not going to bleed from where we access the artery. When that time is done, patients walk out the door. It's as simple as that. There's very little pain in the knee. I mean, nothing more than you had when you came in. A lot of times, like today I did one and the patient said her knee was feeling better than it was when she came in the door. So a lot of times they're even better. But they walk out the door and that's it. So the total day when you come in our center, it's from arrival to discharge. It's usually somewhere between 3 and 4 hours. So we try to make it as easy on you as we can. All right, so what does it look like for the first few weeks afterwards? So you might have some increased soreness for the first couple days. We've seen that in some patients. The access site, meaning the groin or the lower leg where we inserted the foot area where we inserted might be a little bit sore. That usually wears off after a few days. It's pretty mild. We will recommend that you take some over-the-counter pain medication if you feel like you need to, but it's not that bad. Over the first couple weeks, you should start noticing some improvements. Most people see an improvement by 2 weeks. Some people out to a month, but usually the first 2 weeks, some people are noticing an improvement in their knee pain. By 1 month, most patients will have improvement in their knees. And then from month 2 to 6, there will be some continued improvement and patients will start to return to activities that they had given up. Now, the only thing I will warn you about, one thing, and we see this a lot in our patients, we'll do this procedure and man, they're feeling good. Their knee feels so much better and they just want to go out and start doing things. And so we have to caution people, you haven't done this activity for a long time. You need to ease into it and work your way up to it because a lot of times they can overdo it and maybe bring the knee pain back. So that's something we do warn about. All right, what do the results show? So we see improvement in pain and function in about 80% of patients. So it's pretty good. 8 out of 10 chances is pretty good. And then as far as the reduction, it's a little bit over half. So like I was saying earlier, if your pain at the worst is 7 or 8 out of 10, after this procedure, you'll probably be at somewhere like a 3 or a 4 out of 10. And most people, like I said, get relief within the first month. All right, what about safety? So I mentioned this a little bit earlier, but I'll mention again. We haven't seen any major adverse events from this procedure, so that's great. Major adverse events would include things that send people to the hospital or that require additional surgery or long-term medication. What we do see are minor things. Skin discoloration is a big one. We see that in a lot of patients, but it's temporary. It goes away after a month or so or a month or two. And then bruising, we can see that at the access site, but that tends to go away as well. So mostly temporary minor things. And again, I just tell you that we know this stuff because we at IR Centers actually did the research. It's not like we're quoting somebody else's research. We did 2 clinical trials, including a very rigorous randomized controlled trial using a sham procedure. And so we know the efficacy of this procedure and also the safety of it. All right, this is just a chart showing how this procedure compares to other possible options that we talked about. Medications, obviously very easy to take, temporary relief. Steroid, a little bit more invasive, but they tend to work. But honestly, the efficacy, it says 3 to 6 months. In my experience, it's more like 1 to 2 months or maybe 3 months tops. GAE, what we're talking about today, minimally invasive, recovery in time in days, and we've seen it last 2+ years after the procedure. And when it comes to surgery, those are going to be the most durable treatments. So a partial or total knee can last for years and years and years. But obviously, it's a bigger surgery. All right. So why come to IR centers for this type of treatment? And the reason is, again, because we pioneered this in the United States. We did the early research. And we make sure that our protocols are standardized across all the centers. So every interventional radiologist who works at IR centers uses the same equipment and has the same medications, and we standardize everything that we do. And we will tell you when you come in, if we don't think this is a good idea for you, we'll tell you that so that we don't lead you on just to do another procedure. All right, so if you're interested in looking at this further, then this would be the process. So first of all, if you have previous X-rays or an MRI, please bring them with you, or when you do come in for a consultation, and then you schedule a consultation with us, and we'll review your imaging and your symptoms and come up with a plan that's specific to you. At the end of the presentation, I'll give you a QR code to be able to get to our website, but also in the emails you received for this webinar, there was the information for your center that's local to you. All right, so finally, just quick reminder that you may have more options than you think when it comes to knee pain. A lot of people are stuck in that treatment gap that I was talking about earlier, where they think there's nothing they can do and they just have to live with the pain until they're ready to have a knee replacement. But that's really not the case. This is a newer procedure, and it's very effective, and it's a great solution for people who are in that situation. All right, so this is, like I said, if you're ready to, if you want to look into this more and you want to contact IR centers to make an appointment for a consultation, you can scan this QR code with your phone, and that'll take you to the website. To do so, we have 38 locations across the country, and so if you got the email for this webinar, you are near one of those locations, and either you can look in the email that you were given. You were sent for the webinar to find the information for the center closest to you, or you, again, go ahead and scan this QR code. Okay, at this point, I am going to try and get our questions up here. All right, let's see. Do you, I,
I can read them to you if you click on Q&A at the bottom.
okay. Why don't you start reading it? I'll see if I can
Yeah.
figure it out. Yeah.
So, yeah, my name's Alex Puitov. I'm also a physician with IR Centers. So we'll run through some of your questions. Some of these questions are repeated, so I'll try not to do more than one. But does Medicare cover this procedure?
The answer is yes. In most cases, Medicare has covered the procedure. It's certainly not 100%. Anything we answer is there's going to be exceptions, but for the most part, yes, we have seen Medicare coverage for this procedure.
Is prior failure to steroid injection or Synvis injections required before offering or receiving your GA?
No, I would say no. We do, like I said in the presentation, we do want you to have tried some other options. We don't think this should be the very first option for knee pain. But if you're adverse to getting an injection and you've already, tried meds or maybe physical therapy, that would be fine to come in and be evaluated for a GAE.
Can GAE be used after total knee replacement?
Interesting question. That was a good question, Alex. Thanks. Yeah, actually, believe it, there is research on that, and so we've known this for a while. There's not as much research on this as there is on just straight up knee pain, but from our clinical experience and from the limited amount of research that has been done, we do know that it is effective in reducing pain after total knee replacement. So yes, you can be evaluated for that, and it can be effective for that.
One person asked, what exactly is injected into the blood vessels?
Yeah, good question. So it's it could be one of a couple things actually. So one type of embolic or material that we use, or a material to block the arteries, is called imipenem, and that is actually an antibiotic. But when you mix it with the contrast dye that we use for the procedure, it makes these little crystals that can actually block blood vessels. And so we may use that, or we may use an actual microsphere or tiny little particle made of a synthetic material that will block the arteries. Now, all of the materials that we use are not new materials. They've been used for years and years, 20 plus years. And so we know their safety. We know that they're not toxic to the body or leach anything like that. They're inert, and they just basically block arteries. So even though the procedure is new, the materials that we're using in the procedure have been used for a lot longer than the procedure's been done.
Okay, so this patient's kind of going into their specific scenario, but I think it might be helpful for everyone.
Yeah.
So they've had injections in the past,
Yeah.
and they've actually had genicular nerve ablation,
Nice. Okay.
all with minimal relief. Now, does that exclude them, or will the outcome be different with GAE?
So it does not exclude you, and I think it's worth being evaluated, especially where you are, because it sounds like you've tried a lot of the other options, and they haven't worked out. So I think you're an excellent candidate to at least be evaluated. I can't say for sure that you'll be an excellent candidate for the procedure, but I would encourage you to go be evaluated for a GAE.
Okay. Can you have both knees done at the same time?
Ah, well, it depends how many of us there are on that given day at the center. No, the answer is no. We don't do two in one shot. I know some places do that, but I think we found it to be better practice to do one at a time. Make sure that we do the best we can do for one knee and see what the outcome is. If we do the first knee and you get zero relief from it, then it seems silly to go on and do the other knee. So I think the way we do it is we do it sequentially. We do your first knee, we wait a couple weeks, see how it comes out, and then if you want to go on and do the second knee, we'd be glad to do that as well.
Okay, let's see. Some of these are repeats. Oh, any chance you're investigating similar treatments for the hips?
Ah, another good question. Wow, Alex, you're full of them tonight. Um, The answer is yes. It's quite interesting. So we're not actually doing a formal research trial on it, but there is data. Data has been published from other locations on doing a similar procedure for the hip. And at IR centers, we've done a number of these procedures and even presented kind of a retrospective. We presented our experience at a meeting. So we have kind of accumulated our data and summarized it and kind of looked at the efficacy, and we have found it to be effective. So yes, we can do that. And I would, if it's something that if you have hip pain and you're kind of stuck with how to how to fix it, I would encourage you also to get evaluated for a embolization procedure because it is a good option.
Mhm. Here's one from a patient. Any age restrictions or weight restrictions?
You know, when it comes to age, we tend to not do this on really young people. So usually we're looking at people 40 and above. But as far as a max age, there really isn't, as long as we think it's reasonable to do an embolization. And truthfully, we do embolizations on people in their 90s. Like, you know, as long as someone can tolerate the contrast dye, and then it's really not, there's no upper limit. So as far as the age goes, it's fine. What was the second thing? Weight? Was that what it was?
Weight restriction,
Oh
yep.
yeah. Um, yeah, I mean, we have a restriction, a weight restriction on our table. So there is a max weight. I don't know, is it 400 or something like that?
I think it's like closer to, yeah, 450 or 500,
Yeah,
I
I mean,
think.
so there is a max weight, but I would say up to 4 to 450, we could still evaluate you for the procedure.
Um, does insurance, and there's a bunch of questions related to this, but this one, does insurance typically cover the procedure? Is it considered too new or experimental?
Yeah, it's a great question. And the answer is sometimes. So, you know, there's no one blanket answer. We will do our best. We have a team with IR centers who reaches out to the insurance company and tries to get pre-approval for the procedure. And so they'll do that, and we'll let you know, obviously, before we do the procedure if it's approved or not. But there is some degree of inconsistency across multiple different insurance carriers of who covers it and who doesn't. So the best guidance I can give you on that is come in and have an evaluation, and then we'll test the waters with your insurance company, and hopefully it'll work out. Again, Medicare tends to be a little bit more consistent with that, but private payers, a lot of them do pay for it, but we just need to look at your specific situation.
Can you do it on blood thinners?
So most of the time, if you're on a blood thinner, we will see if it's safe for you to come off for a couple days prior to the procedure. But I would say if it is not safe, say you had a recent stroke or you've had multiple blood clots in the past and you really can't come off, yes, I would say yes, we can still do the procedure on a blood thinner. In fact, I would tell you that when we do the procedure, I tend to thin the blood on purpose. So we will give heparin during the procedure to make the blood thinner. So that's definitely doable. Either way, I would say.
Okay. Some of them are saying my orthopedic surgeon said I have bone on bone osteoarthritis. Does this disqualify me?
Yeah, so this term bone on bone gets thrown around really liberally. And so I would say that that does not disqualify you from being evaluated for a GAE. I would still come in, let's look at your x-rays. And if you have an MRI, we'd look at that and really see where you're at and kind of characterize how severe your arthritis is. Just having been told it's bone on bone doesn't give us that final answer. So no, it does not disqualify you from being evaluated for a GAE.
I think you answered this. One of the questions is how long does the effects last?
Yeah,
I see
it's
that a few
variable.
times.
Yeah, I mean, we we will say most. So if about we said 80% of people see a good effect, and of those 80%, another 70% or so have a relief out to 2 years. So there's a pretty good chance of that. But I would say, it varies from patient to patient, but the majority of the patients have at least 1 year, if not 2 years of relief from the procedure.
Um, I'm a nurse working 12-hour shifts. What kind of downtime is there for me?
Yeah. Well, I mean, this is a good procedure for that because there isn't a lot of downtime. We're going to tell you, depending on where you're accessed. So if you're accessed in the foot, that's going to be less downtime. If you're accessed in the groin, we're going to tell you we don't want you to lift anything heavier than about 15 pounds for about 3 days. That doesn't mean you can't work, although as a nurse, depending on what you're doing, you may need to lift heavier things. So I would say the maximum you would need to be away from work is probably 3 days after the procedure. And during that time, your knee may be a little bit more painful too, so that might be a good thing. So I don't know if you work weekends or not, but you could schedule a Thursday or Friday procedure and then take the weekend off and probably be back to work next week.
Here's a question. How much radiation is involved in this procedure versus regular diagnostic imaging?
Yeah, good question. This person knows what they're talking about. So the one thing to know is that fluoroscopy or the X-ray that we use for these procedures is very low dose. So when you go to get an actual diagnostic X-ray, you get a lot more energy in that X-ray so that every little detail in the bone can be seen. When we do our procedures, we're more interested in just seeing the blood vessels, and so we use a lower radiation type of imaging. Now, the other thing to know is that we are focusing most of our radiation on the leg, which is a very skinny, compared to the trunk, is a very skinny part of the body. And so the total doses for the procedures tend to be extremely low. Um, I guess, I give you a rough estimate, and I don't even know how close this was going to be, but compared to like a diagnostic X-ray of the knee, I think our procedures, probably the total amount of X-ray for the whole procedure is probably maybe like a one diagnostic X-ray, something around there.
Piggybacking off of that, is this hard on your kidneys, the contrast?
Yeah, that's a good question. So if you already have kidney dysfunction, then yes, we need to be a little bit concerned about what the contrast is doing to your kidneys. If you have normal kidney function now, the contrast is not going to do anything. It's not going to hurt your kidneys in the least. But if you have something called CKD or chronic kidney disease, then at your evaluation, when you come in to see us, we'll look at how severe your chronic kidney disease is and decide if this is still a safe thing. One thing to note is that compared to other procedures, we use really a low amount of contrast for these procedures. So the volume also comes into play. Most of these procedures can be done with 30 milliliters of volume of contrast or so, or less even. So there's a pretty good chance that even if you have moderate kidney disease, we could still do this procedure for you.
And just a note, Marcus Jones texted me. He said the table limit is 600 pounds.
Maybe in St. Louis.
Um, another question. Can you do this procedure on shoulders as well?
Wow. All right. Yes, we can. And actually, we published a paper on that as well. So we've researched that as well, and it is very effective. In fact, Alex, I would go as far to say that the shoulder embolization is my favorite procedure to do in everything I do at IR centers because patients are already doing so much better when they will leave our table.
Mhm.
And most of the procedures that we do, we have to wait, like we said, we wait a few weeks or we wait a month to see results. But in shoulder embolization, if you have either adhesive capsulitis or frozen shoulder, or you have pain at night from tendonitis or something like that, we can help you with that pain and you can feel better before you even leave our facility.
Let's see here. Some of these have already been answered. Any danger in the particles traveling within the arteries and causing problems elsewhere?
Yeah, that's another good question. So, is there the potential for that? Yes, there's anytime you inject stuff in arteries, there's always the potential for that. But that's where the skill comes in, where the skill of the interventional radiologists at IR centers. We've we've trained everyone that works at IR centers to kind of know how to do these things and to know what's safe and what isn't safe. And so, yes, there is a risk of that, but the risk is decreased by the training that the interventional radiologist has had.
When and how long ago did your center start doing procedures like these?
So knee procedures were, I think, done from the get-go. So IR Centers has been in existence for 5+ years now or so, it's 5, 6 years.
Six years on March 17th. Just
Okay,
turned
so
6 years
just just
old.
had just had a sixth anniversary,
Yeah.
and so yes, these knee procedures have been done 5+ years at IR Centers at this point.
And before that, a lot of our doctors were
Yep.
doing this procedure prior
Right.
to that.
So I started doing this procedure in 2014, so it's been 12 years or so.
Do you need a referral to have this procedure done?
No, you do not need a referral for most patients. There might be an occasional HMO patient that does need some kind of referral, but the vast majority of patients do not need a referral to come talk to us about this procedure.
All right. I think that was a lot of participation. Any dangers of blood clots related to this procedure?
So we have not seen that in any studies. There hasn't been an example of a blood clot that has resulted from a GAE.
Oh, this is a good question. Are diabetics candidates?
Yeah, I would say yes. Now, there's a caveat there with a lot of diabetics, depending on how controlled your diabetes has been throughout your lifetime, you may have considerable calcification of the arteries, and that can make the procedure more difficult or impossible. So, are diabetics excluded? Not at all. No. I mean, I would say if you're diabetic, come in and let's evaluate you. But it's possible that some diabetics may have arteries that are not amenable to the procedure.
And some diabetics may not have options to go for a knee replacement. Oftentimes, they will use that as a criteria, what their A1C is. So, um, oh, is there a follow-up protocol after the procedure?
Yeah, so we at IR centers, we will either call you at a month or see you in person at a month, and then potentially, depending on how you're doing, see you again at another 3 months or something, somewhere along those lines. So there is a protocol, but it's somewhat dependent on how the patient's doing.
I think we pretty much covered. We talked about the referral. I think we pretty much covered all these questions. There's a lot of questions, but
All right, if did everyone who raised their hand put their questions in the chat? Because I see some hands raised.
let
We
me
can't
see.
we can't really call on you, but if you want to ask a question, just type it in and
Yeah, there are. Yeah, and I encourage you guys to scan this barcode. Some of them are like specific patient questions, or like, do we have locations in these certain cities? And this will take you to our website, and it will tell you all the cities. I tried to answer all the city questions,
yeah.
um, best I could. Um,
Yeah, so the page that the QR code takes you to is the GAE or the Genicular Artery Embolization page specific to IR centers. But at the bottom of that page, there's a link to see all the locations so that you can find where your nearest location is.
so yeah, someone's asking, is there a Nashville site? And yes, there is a
Yes,
Nashville
there
site.
is. Yes, there is. Called IR Centers Hot Chicken.
Oh, here's one. I mean, this is patient specific, but does Parkinson's disqualify you for the procedure?
No, it doesn't. No, it doesn't.
Okay. Yeah, I think yeah, a lot of this is about insurance and payers, um, referrals, which we touched base on. Uh, how soon after total knee replacement can GAE be done to relieve pain?
Um, I would. That's a question I would pose to the orthopedist. You probably don't want to go too quickly right afterwards because then the pain may resolve. So you kind of want to give it a chance. But if it's, I would say if it's been a few months and you're still having consistent pain, then that's reasonable to come see us about it.
This one's good. If after 2 years and you had good improvement with your first GAE, can you repeat it, or is it a one-time
Yeah,
procedure?
yeah. I don't know that we have a lot of experience with that, but the answer is yes, you could potentially repeat it.
Yeah, I mean, I think you covered them.
Yeah, I would say if we haven't, if you have a question that we haven't covered, then just go ahead and contact the IR centers, and you can call and ask a question or arrange an appointment. We do a lot of these appointments. We prefer you come in actually for a knee because we want to be able to examine your knee. But if you need also to have a phone call set up, we can set up a phone call as well. All right. Well, I think we are going to end this here at this point. Thank you, Alex, for your help. Probably would have been lost without
My
you at
pleasure.
the end there. Um, and I hope for everyone that joined us, this was informational and beneficial. And I know, I personally work in Raleigh, and Alex is in Virginia. We look forward to meeting some of you and hopefully helping you with your knee pain. So have a good evening, and hopefully we'll see some of you soon. Take care.
Thank you, everyone.